Okay. So we finished the conversation on Tuesday, I'm sorry, the discussion of electrical activity in the heart. Now, look what we have learned so far, because we're going to be putting things together now. We have learned how blood flows through the heart. We have learned how electrical impulse is transmitted from SA node through AV node through the bundles to the Purkinje fibers. And we, what is probably most important, have learned what happens to the chambers at different stages of the electrical signal transmission. Does that make sense? So we're going to be putting the blood flow and electrical transmission, opening and closing of valves, all together now, describing what is called a cardiac cycle. The cardiac cycle essentially describes all the events, electrical, changes in pressure, changes in the muscle contraction, opening and closing of valves, and movement of blood from chamber to chamber during one complete heartbeat. To discuss it, we need to define the terms. And the term for contraction is systole. The term for relaxation is diastole. This term can be used for both atria and ventricles, but obviously we're going to be focusing more and almost entirely on the ventricular systole. And in a minute we will see why ventricular systole sort of is of more interest for us. Okay? So we start here at the stage of ventricular filling. Okay? That's the moment when the heart is relaxed. This is diastole. In diastole, all chambers are relaxed. Basically, it's a period between T wave and P wave on the EKG. That's the time when all muscles are relaxed. Does that make sense? We call it ventricular filling because blood flows directly into the ventricles. Now, when we say directly, what does that mean? Does it bypass atria? No, it doesn't. But during ventricular filling, blood is passively flowing into the ventricles because, well, there is no valve at vena cava, so blood is flowing from the vena cava into the ventricle. And I'm going to be focusing, I started with right side, so I'm going to be talking about right side, okay? Make sense? And then it flows directly from the right side from the right atrium into the right ventricle, because the valve that separates right atrium and right ventricle, tricuspid valve, is open. Does that make sense? Now let me ask you a really, really important question. What keeps tricuspid valve open during this process? What opens and closes valves? Blood flow is secondary. It's blood, but what about blood? Not flow, but pressure. Pressure of blood. So, for tricuspid valve to be open, what should be the relationship, pressure relationship between atria and ventricles? Atria and ventricles. Should be more in the atria. Is that clear? So I show it here. Pressure in the atria is higher than pressure in the ventricles. Does that make sense? Now, what about the semilunar valve? This one. Is it open or closed? It is closed And why is it closed? Think about pressure relationships again. Because pressure in... No. What does pulmonary valve right here? What does it separate? Pulmonary trunk and right ventricle. So it is closed because what? What are the pressure relationships? Meaning that pressure in the vessel is higher than pressure in the ventricle. Does that make sense? So at this point, ventricular pressure is the lowest. And we need to focus on these three. That's it. We're clear. So ventricular pressure is the lowest. AV valves are open. SL valves, semilunar valves, closed. Blood passively flows into the ventricles. Sorry. And at the very end of ventricular filling, atria starts to contract. So that's atrial systole. You see that atrial systole delivers only about 20% of all the blood into the ventricles. So it is important, but not terribly important. Does that make sense? Now, I'm going to introduce a very, very important concept that we're going to be using a lot, and I'm going to be asking you about this concept a lot. It's end diastolic volume. So that's, as you can guess from the name, the amount of blood in the ventricle at the end of diastole. Are we clear? By definition, look, at least blink once, or I don't know, shake your ears or something. Okay, we clear? This is the maximum amount of blood that gets into the heart, into the ventricle. Does that make sense to you? So end diastolic volume is how much blood can be in the ventricle before it starts contracting. Is that understood? Okay, good. So if my mouth is the ventricle, look, that's end diastolic volume. Okay, that's how much air I can get into my mouth, how much blood we can get into the ventricle. Does that make sense? And then ventricle starts to contract. Now, very interesting thing happens at this point. So when ventricles contract, what happens to the blood? To the pressure inside of the ventricle? When they, Exactly, it starts to rise. Now, here's the deal. At some point, pressure in the ventricle will become higher than the pressure in the atria. When pressure in the ventricle becomes higher than the pressure in the ventricle, what happens with the, in this case, tricuspid valve? It closes. Now, the interesting thing is that pressure in the ventricle is still lower than the pressure in the vessel. Is that understood? So you have this relationships. When pressure in the ventricle is in between pressure in the atria and the pressure in the vessel. Does that make sense? Now at this point, which valves are closed? So again, all of them. This is called isovolumetric contraction phase. We call it isovolumetric because the volume of either ventricle doesn't change. Do you see that? Okay. Well, technically speaking, I should correct myself. It's not volume. Volume of the ventricle, of course, will change. Volume of the blood in the ventricle, sorry, doesn't change. You see what I'm trying to say? There is no incoming blood. So volume of the blood, we should say. Okay? Now, ventricle continues to squeeze. What happens to the pressure in the ventricle? Keeps rising, and at some point, ventricular pressure becomes the highest. It becomes higher than in the vessel, and it stays higher than in the atrium. In this situation, when ventricular pressure is the highest, which valves open? Semilunar. And blood is ejected into the vessels. Are we clear? Does that make sense? So this is ejection phase. Now, when blood leaves the ventricle and, listen closely, enters the vessel, what happens with the pressure in the vessel? Increases. The pressure in the ventricle eventually decreases. Does that make sense? So that change in the pressure will lead to the closure of both pulmonary and aortic valves. Does that make sense? Because now the aortic pressure or pressure in the pulmonary trunk is higher than the pressure in the left ventricle or right ventricle, respectively. Do you understand what I'm saying? To prevent the backflow, aortic or pulmonary valve, they close. Now, another super important term. At the end of ejection, after all the blood that could be possibly ejected is ejected, there is some volume of blood that's left in the ventricle. It's called end systolic volume. So this is the volume of blood that stays in the ventricle after the systole. Are we clear? Basically, in sort of conceptual terms, end systolic volume shows you what percentage of blood can be ejected and what percentage of blood cannot. I usually use analogy of the damp cloth. Okay, so take a piece of cloth and you soak it in water and you take it out, let it drip. The cloth absorbed some water. Does that make sense? It cannot absorb anymore. And then you squeeze it. So you squeeze some water, but the cloth remains wet. So that amount of water that stays in the cloth after you squeezed it, that's end systolic volume. Does that make sense to you? Now, since blood has left the ventricle, the pressure in the ventricle precipitously drops, and aortic and atrioventricular valves open up again, and ventricular filling starts again. Cycle is complete. We're clear. By the way, that stage when all valves are closed and muscles of the ventricle and atria continue to relax, this stage is called isovolumetric relaxation, because no blood is coming in or out of the ventricle. So during isovolumetric relaxation, just as during isovolumetric contraction, blood pressure in the ventricle is higher than blood pressure in the atrium, but lower than blood pressure in the vessel. I'm thinking how to formulate the question. Did you follow me? Do you have any questions about events so far? Now, I didn't see any no's, so we're going to go over the same process in more details over looking at the events, looking at the valve sounds, looking at the P waves, T waves, QRS complexes, all right? So it all starts to make even more sense. Got it? Cool. First of all, valve sounds. So you can listen to them. The 4 valve sounds. These dots give you the approximate locations for the sounds. So on top there's going to be aortic on the right side of the sternum, the level of second rib, and pulmonary on the left side of the sternum, and then tricuspid, right side of the sternum, fifth rib, mitral, left side of the sternum, fifth rib. Okay, basic general idea where to auscultate the sounds of the respective valves. Okay, good. Now, the sounds are when valves close, not when they open. So the first sound that you hear is when isovolumetric contraction starts. And the second sound that you hear is when isovolumetric relaxation starts. Okay? If valves are defective, stenotic or incompetent, or have some kind of infection like endocarditis, you're going to hear heart murmurs. Murmurs reflect the backflow, the regurgitation of the blood through the incompetent valve. Okay? You ready to tackle this whole story? Okay, let's do it. First, ventricles are passively filled. Any electrical stimulation, any electricity going through the heart? Nope. Muscles are relaxed, right? Relationships in terms of the pressure. Look at this graph. That's going to be one of our major focuses, the pressure graph here. The purple one is atrial pressure. The blue one is ventricular pressure. The green one is aortic pressure. So you see that aortic pressure are pretty high. Ventricular is the lowest. Atrial is in between. Correct? So you have atrioventricular valve open, blood passively flows into the ventricle. Okay? Then P wave happens. P wave, what does it indicate? The start of what? Cheers. Depolarization of the atrium. That makes sense? That's wave of depolarization, and atrial contraction starts at this point. So that's atrial contraction right here. You can see this if you're able to measure the pressure in the atrium. You would see this, that's atrial systole. P wave basically corresponds to atrial systole. Does that make sense? So atrial systole pushes the rest of the blood into the ventricle, and that elevated pressure closes the valve. Now this right here is the valve closure. And you see that valve closure, and the moment when pressure in the ventricle becomes higher than the pressure in the atrium, that moment matches QRS complex. What happens during QRS complex? Two things. What happens in the atrium? Repolarization. You can use relaxation and relaxation, right? What happens in the ventricle? Depolarization and contraction. So atrial relaxation and ventricular contraction close the valve. And that's QRS complex reflects that as ventricular depolarization, atrial repolarization. We clear? Now during that particular moment, That's when you have your end diastolic volume. We clear? Remember we were talking about the plateau? That's your isovolumetric contraction. It's right here. That's isovolumetric contraction. Now remember we were talking about the plateau that calcium facilitates. Remember? So that's your plateau. The plateau keeps going, and at some point that long squeezing heart, long squeezing ventricle, develops the inside pressure that is higher than the aortic. You see that movement? It's marginally higher, but it is higher. So blood starts to flow into the aorta. That's going to be the ejection phase, 2B, ejection phase. Does that make sense? Blood flows into the aorta, flows, and then you see that the jump in the pressure in the aorta, called dichrotic notch. I'm sorry. That's the moment when aortic pressure becomes higher than ventricular. So that's the moment when pulmonary or aortic valve, SL valve, closes. Does that make sense? And partially it closes because ventricle starts to relax. So that will be the T wave. T wave essentially is matching the start of isovolumetric relaxation. Does that make sense? We good? Pressure in the ventricle precipitously drops, goes beyond the pressure of the atrium. Atrioventricular valves open, and the whole cycle starts over. So in terms of the matching EKG to the events, we can basically say this. So atrial contraction is going to be matched by P wave. Start of isovolumetric relaxation is QRS, complex. And start of isovolumetric contraction, and start of isovolumetric relaxation is a T wave. Does that make sense to you? During isovolumetric relaxation phase, the amount of blood that is left in the heart is called end systolic volume. So essentially this part, that is systole, and the blue part is diastole. Are we clear? Here are the questions that I can ask you. During isovolumetric relaxation phase, which valves are open? Well, I know that you know. I'm giving you examples. None, right? During ejection phase, what are the pressure relationships in the heart? So you have to select the correct statement. Does that make sense? Or during isovolumetric contraction phase, what are the pressure relationships? So ventricular pressure is in between. Do you understand what I'm saying here? Atrioventricular valves close when isovolumetric contraction starts. Semilunar valves close when isovolumetric relaxation starts. Do I make it clear? That kind of questions. You really have to image it. You're more than welcome on the exam. You're more than welcome to draw anything you'd like. Okay, any references, as usual, brain dump is very much welcomed. Okay. What else I can ask you? Yeah, we'll get to EDV, ESV, okay? I can ask you, P wave marks what? Atrial contraction, yes.
What would be an example of like the valve sound? Like, would you ask anything about those? Like the location of them?
Well, no. No, I'm not going to ask you about the location of the valve sound. It would be great if we would be able to altogether comprehend this, because that's a lot. But this is something I want to tell you. Something, in my opinion, really important. I don't remember if I brought it up to you. Is anyone going somewhere on the spring break? Well, good. I'm not asking where. Just you going somewhere, right? If 2 weeks from now I will ask you, how was it? Will you be able to tell me? Probably so, right? And how would you tell me this? Do you have like a whole list, like a text in your head that you memorized and you just spit it out? No, not really. You remember the imagery, you remember what you've done, right? You have an image in your head. Does that make sense? You have to be able to do the same imagery stuff with physiology. Unless you can imagine what's going on in the heart, like blood flows from here to here, pressure goes up, pressure goes down, muscle contracts because there is an electrical impulse that goes from SA node through the atrium. You see? Unless you can spell it out and make it more of a story that you can imagine rather than the text, that would be awesome. The best way, in my opinion, to study this is just to draw the muscle and draw the events in the muscle. Did I make myself clear? Can we move on? Now we're going to be talking about some arithmetic. I know it sounds boring, but it's pretty exciting, really. So far I introduced you to the concept of end diastolic volume and end systolic volume. If I tell you that end diastolic volume is 200 mils and end systolic volume is 100 mils, those are completely made up numbers, by the way. What's the amount of blood that was ejected? 100. Do you understand that the amount of blood that is ejected, so-called stroke volume, is a difference between end diastolic and end systolic? Are we clear? So that's your stroke volume. Does that make sense? People, does that make sense? Okay, good. Speaking of which, just quick thing. So look at this equation. EDV minus ESV. How can you increase stroke volume? Mathematically. How can you make stroke volume, the amount of blood ejected in the circulation in one beat, how can you make it bigger? Huh? I'm talking about math, folks. Like, you have SV equals EDV minus ESV, right? Stroke volume equals EDV minus ESV. What do you need to do to make it bigger? Bigger EDV or smaller ESV. Does that make sense? That's it. How can you make it smaller? Smaller EDV, yeah, vice versa, or bigger ESV, right? So the whole modulation, we'll get to exercise, but the whole modulation of stroke volume is through these two parameters. Does that make sense? So this table No, hold on a second. So this table you can tease this out. Stroke volume is increased when end diastolic volume is increased or end systolic volume decreased, or both. And it is decreased if, the opposite. Which brings us to the concept of cardiac output. So cardiac output is amount of blood that each ventricle pumps in 1 minute. And this amount of blood is actually equal to the blood volume. So we have about 5.25 liters of blood, and we pump 5.25 liters of blood per minute. That's just observation. Does that make sense? And now, here's the deal. How can you calculate how much blood is pumped in 1 minute? You need to measure stroke volume, and you can do it using echocardiography, okay, ultrasound of the heart, and you need to count the number of beats per minute. If one beat delivers 70 mils, then 75 beats will deliver 5.25. Does it make sense? Now, cardiac output at rest is constant. You understand what I'm saying? So let's say you're going to put me somewhere in the bench and let me relax. And you're going to measure my cardiac output. And it's going to be 5.25. Okay? And then you're going to, by some magical meaning, change my heart. You're going to make the chambers, the ventricles, smaller. So since they are smaller, I'm talking really primitive, really hypothetical situation. If they're smaller, which parameter will be changed? EDV or ESV? EDV, the amount of blood that can get in the ventricle. And how is it going to be changed? Decrease, yeah. So stroke volume will go down. But look, the rest of my body hasn't changed. It requires the same amount of blood. Does that make sense? So if my stroke volume decreases, what should go up? My heart rate. To pump the same amount of blood over a minute. Does that make sense? Is that understood? Think of it, look, it's all about pumping. This is plumbing story. You have a bunch of pipes and you have the main pump. And that's it. That's all about plumbing. Okay? So it's like you can think in the terms of a regular pump. If you use, the big floor-based pump to pump the bicycle tires, it's going to take you maybe 30 seconds. If you use tiny little hand pump, it's going to take you 2 minutes. Because you have to work much harder. Does that make sense? Understood? So cardiac output equals heart rate multiplied by stroke volume. Do we understand that equation? In regular folks, cardiac output can be increased 4 to 5 times. Either by heart pumping harder or heart pumping more frequent. Does it make sense to you? Or both. In athletes, it can be up to 7 times more. The difference between maximum cardiac output and resting cardiac output is called cardiac reserve. Does that make sense? Now, let's see, and we're going to spend some time here because please, if you don't get it, if you don't understand what we're talking about, don't hesitate to tell me, look, I don't understand this. Can we go over it? All right? Because that's really important. There are going to be quite a few questions about it. First, what affects end diastolic volume? To answer this question, we need to recall what it is. And it's amount of blood that goes in the ventricles before they start contracting. So they are filled, ventricles are filled with blood during diastole, right? The longer the diastole, the more blood can flow in the ventricles. Does it make sense? Do you understand what I'm saying? The longer the relaxation period, the more blood can go in the ventricles. We good? Longer diastole. What does it mean in terms of the heart rate? Slower. So generally speaking, slower heart rate, not deliberately slower heart, but let's say my heart rate is 60 and Michael Phelps's heart rate is 40. It means that his end diastolic volume is going to be much higher than mine because his heart is relaxed for a longer period of time, allowing more blood to flow into the chamber. We good? Second, venous pressure, or sometimes it is called venous return. Your veins, vena cava, superior and inferior, are the vessels that bring the blood into the right atrium, or your pulmonary veins are bringing the blood to the left atrium. We clear? Does that make sense? Now, here's the question. What can increase venous return? The main thing, as Ebony mentioned, exercise. Turns out, when you exercise, you squeeze the blood through the veins and you increase the amount of blood that is returned into the heart. Does that make sense? We good? Cool. So increased venous return or decreased heart rate will both increase EDV. Now, what about end systolic volume? What can make blood stay in the heart? What can prevent the blood from leaving the heart into the large vessel? Well, resistance. Does that make sense? And by resistance, I mean blood pressure. Imagine your heart has to pump against the pressure. We good? If pressure in the aorta or in the pulmonary trunk is higher than normal, then blood will have to do extra work or leave more blood as ESV. Does it make sense to you? Another thing that can affect ESV is contractility. Contractility is the strength of the cardiac contraction. How you squeeze the cloth. You can squeeze it really hard or really weak. If you squeeze it really hard, if you squeeze the heart really hard, then you're going to pump much more blood. So basically, contractility greatly depends on the structure of the cardiac muscle. Are we clear? We good?
So, the contractility, can that be, like, would having a heart attack change that?
It will decrease contractility, of course. Imagine you have a muscle, like, I don't know, quads, okay? And they have certain strength. And then something terrible happens, and the part of the quad is replaced with connective tissue. They're going to become weaker, right? Does that make sense? The question that you should have asked at this point is, why do we need to change cardiac output? And I would reformulate this question. In which direction do we usually need to change cardiac output? We always think from the baseline, right? say now you are fairly relaxed. Your cardiac output is at the baseline. Do you need to reduce it? Well, if you reduce it, you're going to pass out. So no. In which condition do you need to increase it? Exercise. Any physical effort. And you do physical efforts all the time. You walk, you run, I don't know, you carry things. So you need to increase cardiac output. Does that make sense? Sometimes you need to maintain it. So you lose some blood. Think about cardiovascular system as plumbing system. You have a pump and you have vessels. And suddenly you lose some of the liquid in that closed system. In order to maintain the same pressure in the system, you have to start pumping harder. Does that make sense? In order to maintain the same cardiac output, in case of the blood loss, you have to make some adjustments. Are we clear? So, the general concept of regulating cardiac output. I am really proud of that flowchart at the bottom. It may seem really hard to read, but I'm still very proud. So we're going to start from we're going to go backwards. So this is the outcome that we're looking for. Cardiac output elevated. That makes sense? What can elevate cardiac output? If you look at this equation, what can make it higher? Heart rate or stroke volume? So, how can we increase the heart rate? Sympathetic stimulation. First and foremost, just sympathetic stimulation. We're going to talk more about it, but you understand, right? Norepinephrine, your heart rate starts to beat like crazy. Okay, you shoot yourself with adrenaline, you get like Jason Statham in an eponymous movie. Now, what can affect the stroke volume? What can increase it? Two options. Give me those. They're right there, but I want you to spell them out. Elevated end diastolic volume or decreased end systolic volume, or both. Does that make sense to you? Good? Now, how can you increase EDV? Increased length of diastole or increased venous return. How can you decrease ESV? Either drop the arterial pressure or increase contractility. Does it make sense? Now, I want you to understand what this flowchart does here. It shows you all the options. Can you imagine can you imagine a situation when you cannot do anything about EDV in a patient? Well, the patient is, about to have a heart attack or has pretty bad heart. You can't tell this patient, just go and exercise and train yourself to death, right? You can't do that. What you can do, you look at the patient has a blood pressure, ejection fraction is pretty small, so you give, drugs that will decrease the blood pressure to decrease ASV. Or you look at the heart and it doesn't, work terribly well, contractility is pretty low, you give stimulants to increase contractility. Does that make sense? Or you can tell, oh, you're healthy, but go and exercise and you will increase the length of diastole because you're going to train your heart and it's going to be stronger and bigger. We good? Now, three main aspects that regulate stroke volume. First aspect is preload. So preload greatly depends on the venous return. So think about it for once. So preload determines how much blood will be ejected from the heart. And it follows so-called Frank-Starling law. Okay? So this is the description of preload in the left bottom corner. Okay? Here, this graph. This graph represents the relationship between the end diastolic volume and the stroke volume. You see that this relationship is not linear. Here's the story. When heart is stretched, cardiac muscle is stretched, it turns out it contracts stronger. The more it is stretched, the stronger the contraction. Does that make sense to you? Think of it as a coil. The more you stretch the coil, the stronger it will snap back. We clear? So that's the idea. When cardiac muscle is stretched by blood that comes back from vein, its force of contraction increases. Does that make sense? So, end diastolic volume increases twice. Stroke volume increases even more than twice, like 2.3 times. Because if you think about it, it can be kind of a problem. You take more blood in, you got to have the power to eject it. Does that make sense to you? So that's preload. Ability of the heart to increase the force of contraction when it is stretched by increased venous return. So, what increases? Well, as we mentioned, preload can be increased by decreasing the heart rate and exercising. Contractility. We already used this term for the force of cardiac contraction, how strong the contraction is. If you look at the graph number 2 in the right upper corner, you will see that the first one, the first curve, represents sort of a baseline. Baseline of dependence between the stroke volume and end diastolic volume. But when you start to stimulate the cardiac muscle with some kind of sympathetic stimulation, it can be directly by norepinephrine via blood, you see that these curves shift to the left and top. Can you see that shift? Now, what does that mean? Let's take a look at the graph. So let's take this EDV1. You see that EDV? Now, in the first curve, sorry, that's a good one. EDV1. On the first curve, that's corresponding stroke volume. Now look at the second curve after sympathetic stimulation. It's going to have stroke volume 1 prime. And on the third, stroke volume 1, 2 prime. So what is the relationships between all these three stroke volumes? As sympathetic stimulation increases, right, stroke volume becomes higher. Does that make sense? Do you understand what I'm saying or not? So basically, when heart feels to a certain volume, when cardiac muscle gets stretched to a certain degree, it contracts with a specific force. If you will add norepinephrine, the force of contraction at that specific length will increase. More norepinephrine, more increase. More norepinephrine, more increase. Are we clear? This is called the force of contraction, refers to contractility. System that regulates contractility is sympathetic. Agents that increase contractility are called positive ionotropic. Does that make sense? So that would be epinephrine, norepinephrine, calcium, thyroxine, and glucagon. Does that make sense? So positive ionotropic agents. You need to know this term and what it means. And among positive ionotropic agents, I want you to know three: thyroxine, epinephrine, calcium. You good? Now, chemical agents that, bless you, that decrease contractility, called negative ionotropic agents, acidosis, and elevated extracellular potassium. They will decrease the force of contraction. Does that make sense to you? You need to know two: acidosis and extracellular potassium. Now, potassium again comes up in the conversation. Did we talk about capital punishment in the United States? Yeah, so potassium again comes. It explains, how potassium stops the heart. And this is why potassium concentrations in the extracellular fluid are extremely tightly regulated. Okay. Does that make sense so far? Good? Awesome. Now, before we move on, let me ask you this. Increased preload, increased amount of blood that flows into the heart and stretches it to a great extent. How will it change stroke volume? Look at the graphs. Increasing. Increased contractility. How will it change stroke? Increased. Afterload is opposite. Afterload refers to the resistance that blood pressure imposes on the blood that is ejected from the ventricles. So let's say somebody has high blood pressure. Now heart has to work against resistance in the aorta or pulmonary trunk. Does that make sense? So this is afterload in a person with a healthy heart. So you see, afterload is stroke volume is pretty constant in the range of the normal blood pressure. But when the person with a healthy heart becomes hypertensive, afterload increases and stroke volume starts to decline. You see that? Now, in people who are categorized as having heart failure, moderate or severe, you see the dependence of stroke volume from afterload is even higher. So for those folks with partially dysfunctional hearts, it's even more important to maintain low to normal blood pressure. Does that make sense? Unfortunately, in the majority of cases, the heart problems are often associated with hypertension and can be caused by hypertension. Does that make sense? Good? So you have to be able, first of all, you have to be able to kind of match the term to the definition. Resistance to ejection when blood pressure is afterload. Okay. Stretch of the cardiac muscle due to the venous return, preload. Second, you have to be able to tell what's going to happen to stroke volume or cardiac output. It's the same, basically, if we increase preload, decrease preload, increase afterload, decrease afterload. Does that make sense? Now, before we move on, which parameter, end systolic volume or end diastolic volume, is affected by afterload specifically? End systolic volume. Very good. Because the resistance to ejection will determine how much blood will be left after the systole. We good? Does that make sense? Now, we got cardiac output, regulation of the heart rate, sympathetic and parasympathetic systems. Now, important thing. Sympathetic and parasympathetic systems both regulate heart rate. Contractility, the force of contraction, is entirely sympathetic business. Am I clear? Parasympathetics are not involved in contractility. So, sympathetic. Norepinephrine binds to the receptors, increases the frequency of pacemaker potentials, increases the frequency of firing, higher heart rate. Acetylcholine coming out of parasympagus nerve, okay, opens potassium channels on the pacemaker cells. Potassium flows out of the pacemaker cell, hyperpolarizes it, decreases heart rate. We good? Agents, generally speaking, agents that will increase heart rate are called positive chronotropic. I want you to know, guess what? 3 of them. Epinephrine, norepinephrine, let's put them in the same category, shall we? Thyroid hormone, or thyroxine, and extracellular calcium. So basically, if you inject calcium IV, you will elevate both heart rate and cardiac and stroke volume in a patient, because it's both positive ionotropic and positive chronotropic agent. Negative chronotropic agents, the ones that decrease heart rate, acetylcholine, extracellular, potassium. Okay, those 2 I want you to know. Does that make sense? Now, you see, heart rate is regulated by more than one mechanism. For instance, when you are exercising, your sympathetic system is activated, increasing the heart rate. But not only this, when your venous return, as the result of that exercise, increases, atrial filling and the stretch of atrial walls will additionally stimulate SA node. SA node will start to fire more frequently, heart rate will go up. So I want to highlight how important it is for our renal system to maintain the proper iron concentrations in the blood. Because these are effects of abnormal concentrations of calcium and potassium in the heart. You see that elevated calcium will increase heart rate, which is a problem, but not that much. But low potassium will lead to the lower heart rate and lower contractility. That makes sense? Now, usually getting too much calcium is a bit hard. Overloading on potassium is technically possible because there are plenty of foods that contain potassium. But it turns out, we're going to talk about it, that kidneys provide very tight control systems for potassium concentrations. Because if potassium is really high, not only it will cause decreased heart rate and may lead to cardiac arrest, it will also decrease the contractility. So far, I told you the list of ionotropic agents that you need to know, both positive and negative, and chronotropic. Any questions before we moving on? So that's kind of a summary, this flow chart. So look at the effects of exercise. Bless you. Exercise. Exercise activates so-called skeletal, muscle and respiratory pumps. So the question is, how blood is going back to your heart. Think about this. When you contract the muscle, muscle squeezes the veins that run through it. Does that make sense? And pushes the blood towards the heart. Because valves inside of the veins prevent the backflow. You know the recommendation when you take a really, really long flight to periodically stand up and walk around? The reason behind this recommendation is absolutely valid. When you sit for an extended period of time, the blood in your peripheral veins, great saphenous, small saphenous vein, fibular vein, so on and so forth, blood becomes stagnant because flow is really slow. Does that make sense? And it may promote formation of clots and eventually increase your risk of a stroke or myocardial infarction. When you walk around, muscles in your lower leg squeeze and they pump the blood through the veins. Respiratory pump works this way. When you inhale, your chest expands, your abdomen squeezes, and the blood from the abdominal veins, basically abdominal aspect of the vena cava, will be pulled into the heart, increasing venous return. Does that make sense? So when you exercise, all this muscle squeezing and intensive breathing will increase the venous return. Or slower heart rate will do the same. Now increased venous return increases the preload, increases end diastolic, meaning increased end diastolic volume, which increases end stroke volume. Okay? Good? Now, sympathetic stimulation will increase contractility, which will decrease end systolic volume and increase stroke volume as well. You good? And exercise or sympathetic stimulation will increase the heart rate. Now you see increased heart rate and increased stroke volume both increase cardiac output. You with me? Any questions on this? That's good. So we're going to chat about some abnormalities associated with afterload. So first of all, let's talk about effects of afterload. You are muscle and you're pumping blood in the aorta. And, your owner is getting older and develops hypertension. And now you have to pump blood in that same aorta, but against a higher aortic pressure. Does that make sense? So afterload goes up. As a muscle, what's going to happen to you when you pump harder? You're going to get... Cardiac muscle doesn't really get tired. It gets stronger, thicker, to produce more substantial effect. And this is what we see here in this left ventricle and here in this left ventricle. See how massive the ventricular walls are compared to the normal heart. Okay? You can actually see it in this micrograph. This cardiomyocytes are much bigger and the nuclei are bigger than cardiomyocytes, the normal heart. So you have abnormal, pathological cardiac hypertrophy. It's called cardiomyopathy. In some cases, left ventricle and right ventricle, they become dilated. So same muscle has now squeezed more blood, and it cannot work as efficient. I'm sorry, that wasn't my intention. And it cannot work just as efficient as the muscle in the healthy heart. Does that make sense? So this is dilated cardiomyopathy on the right one. That's dilated cardiomyopathy, DCM. In both cases, either myocardial hypertrophy or dilated cardiomyopathy, heart cannot pump as well as it used to pump. And that may happen on one side. Remember what we learned about the amount of blood that is pumped through each circuit? What is that? Volumes of blood that are pumped through each circuit are what? They are the same. Now, imagine this situation. Your left side fails. So your left side is not pumping efficiently. So it doesn't move the adequate amount of blood to the tissues, and blood starts to back up in pulmonary circuit. Before we move on, do you understand that idea? That if left side, systemic side fails, blood will back up in the pulmonary side. So backup of the blood leads to the pulmonary hypertension and pulmonary edema. And generally speaking, pulmonary hypertension there's a condition known idiopathic pulmonary hypertension, which idiopathic means unknown cause. Idiopathic pulmonary hypertension is untreatable and leads to the death in the span of 1 to 2 years. Now, in pulmonary hypertension caused by the heart problems, caused by congestive heart failure, patient will develop pulmonary edema. And if you take an aspirin from the patient's lungs, you can find a distinguished heart failure cells. When blood will start to seep from the pulmonary capillaries into the alveoli of the lungs, your alveolar macrophages will start consume red blood cells and will acquire a bunch of the protein called hemosiderin, which contains iron. And that gives a very clear clinical picture. Now, in the right side failure, patient will develop peripheral systemic congestion. So it will be characterized by edema in the various organs, elevated systemic pressure, backup of the blood will specifically affect portal system, leading to portal hypertension, okay, hepatomegaly, and splenomegaly. Those organs receive a lot of blood, so congestion will affect their size quite considerably. So treatment is rather futile. So you can reduce afterload, you can increase contractility with the drugs, but ultimately the treatment is actually, I didn't put it here, but it's a heart transplant. Because Everything else is sort of palliative treatment. Okay. It's kind of cool, but I don't know if we have time. Can you hold on for a second? Just 1 second. I'm sorry about it. I just need to check something to see if. Hold on. All right, we're gonna chat about some of the abnormalities quickly, review the quiz, and then I'll run and print. Yes, we will, absolutely. Let me just, you know what I'm gonna do? I'm gonna be smart, well, as smart as I can be, considering what I've done here. And okay. That's okay, that's good. 25, no staples, both sides, long age. Okay, so by the time we're done with the stuff, we should be able to. Okay, embryonic hearts. Starts basically as a tube, okay, with the sinuses, atrium, ventricle, bulbous cordis. That's, as you can imagine, I'm not going to ask any of the anatomy of the heart. What I want to highlight is that in fetal heart, aorta and pulmonary trunk are connected by the ductus arteriosus. Does that make sense? So aorta and pulmonary trunk, systemic and pulmonary circuits are connected. There's no need to separate them. Why? Babies don't breathe. They receive oxygen through placenta. They don't breathe, right? So there's no need to separate the circuits that lead to the lungs from circuits that lead to the tissue. That's the main outcome. So foramina ovale connects to atria in babies. So when babies are born, it's basically is closed. And we'll talk about what happens when it's not closed. So in adults, this is fossa ovalis, and the remnant of the ductus arteriosus is ligamentum arteriosus. It's kind of degraded. Now, main congenital problems. Shunts. So this is atrial septal defect. Opening in the atrium, and since systemic side has the higher pressure than pulmonary side, blood from systemic side will enter the pulmonary side. Does that make sense? Same is true for ventricular septal defect. So that's open ventricle. The ventricular septum is open. Okay? Same story, blood will enter the pulmonary side. First outcome, think about this. More blood than needed on the pulmonary circuit, pulmonary hypertension. Oxygenated and non-oxygenated blood mix, cyanosis. Lack of proper oxygen delivery to the tissues. Thrombosis, heart failure, and all other terrible stuff. Okay? Now, I'm not going to ask symptoms, but I want you to be able to identify description, term description. So, failure of closing interventricular septum, ventricular septal defect. We good? Third one is patent ductus arteriosus. That's when the connection between the pulmonary trunk and aorta do not close, so you lose some of the blood from aorta into the pulmonary trunk. Basically, these three cases, atrial or ventricular septal defect or patent ductus arteriosus are mixing pulmonary circuit and systemic circuit. Good? Tetralogy of Fallot. Septal defect. Okay. Subpulmonary stenosis, meaning that pulmonary trunk is narrower than normal, which is, so aorta overruns the defect. So you see, due to the size of aorta and elevated pressure on the right side because of the stenosis, the blood will go from the pulmonary side to the systemic side. And right ventricle hypertrophy, because right ventricle will work against elevated afterload due to the pulmonary stenosis. The main outcome, cyanosis. Now this condition fascinates me. Look at the left. Aorta, or this one. Aorta, what is it connected to? Right ventricle. In pulmonary trunk, left ventricle. So pulmonary circuit and systemic circuit are completely isolated from each other. Unless it's called transposition of great arteries. And if it's in this pure form, just transposition of great arteries, it's incompatible with life. Because there's no oxygen getting to the tissues from lungs. But there are often shunts, like this septal shunt, ventricular septal defect. Can you see that? Which allows some mixing, some oxygen, so it's fixable surgically. But it may lead to hypertrophy, the right or left ventricle. Does it make sense? Now the last thing, quickly chat about the last. So basically, you've got the following problem: 1, septal defects; 2, abnormally shaped or abnormally attached great vessels; and 3, aorta is narrowed down. It's called coarctation of aorta or aortic stenosis. So in this case, as you can imagine, now that's an interesting story. Look where coarctation happened. Right after the blood vessels, the brachiocephalic trunk, left carotid, and left subclavian, right at the after the blood vessels that deliver the blood to the upper part of the body. Does that make sense? So blood will kind of be directed towards the upper part of the body, which will lead to elevated blood pressure in the hands, arms, and lower blood pressure in the legs. Does that make sense to you? Okay.